I am by trade, certified registered nurse anesthetist. And then my PhD in research is really in physiology and biophysics. I was a professor at Georgetown University for over 25 years, and I taught graduate nursing students and medical students on a variety of topics, and certainly ketamine was one of the topics that I covered for both groups of students. So how many of you right now provide IV ketamine? Oh, awesome. Okay, very cool. And how many of you also provide other IV infusions? Okay, very good. And how many of you have the goal of extending the effects of ketamine? Right? So this is kind of an area that became of great interest to me as well. So today what I'd like to do is just share with you a little bit about kind of the background, and some of it may be stuff you're familiar with, some of it may be stuff you were familiar with and have forgotten about, and just talk a little bit about, why we even think glutathione would have been a good idea to add as an adjunct to ketamine. So what are the mechanism of actions of ketamine? What's the mechanism of action of glutathione, which is the adjunct that we use? Why did we even come up with the hypothesis? Tell you a little bit about how we actually did the research, and then what our findings were. If you have any questions while I'm talking, just raise your hand, and there is a microphone up here. We can maybe pass it, but it's a small enough room, I'm sure we can all hear each other. So just a little bit about, and I know I'm preaching to the choir when I tell you that MDD in particular is a major problem in the country, because not only does it affect so many people, almost 9 million people suffer from major depressive disorder, and then a third of those people, so 2.8 million around, are kind of in this category, or a third of them are in a category of treatment-resistant depression. And those are, I think, mostly what we see in our clinics that want to receive ketamine. And then I really like this study because it actually gathered data from private insurers, Medicare, Medicaid, and the VA. And what they also did was they did an economic analysis, an economic burden. And what they found was that it actually causes, a 43.8 billion, which to me is a big number, which are attributed just to treatment-resistant depression. And then actually double that is what it costs to treat this population. And interestingly enough, because people are so sick and not functional, there is also a huge burden on unemployment and really a productivity burden where there's lots of absenteeism at work as well. So not only does this impact a lot of people, and this is just a subset, by the way, of patients with mental health disorders, right? This is a very small subset. It's about a 3% subset of the larger portion. But then if you were to extrapolate this, you can imagine what an issue we are all trying to grapple with. So what are the causes of depression? Well, this is kind of where, there is lots of interesting phenomenon that actually tend to be interrelated, right? So there is a whole idea of familial polymorphisms. By the way, there was a study that just came out last week in Cell that found 697 genetic variants associated with major depressive disorder. So if you're wondering, hey, I'm doing the same thing, why is it not working? Because it seems like every brain with MDD is almost like a snowflake. They're all a little bit different. They all have different SNPs. And now you put that together with all the other factors like personality, right? Psychological personality traits, or some of the environmental childhood trauma. Once you start to put all of that together, then we can start to Okay, well, there goes my recording. So then it kind of tends to make sense that, wow, there is actually this issues that is has a lot of different factors. And that's why sometimes maybe the treatment, if we know what the cause of something is and it's one or, unifactorial, we can much easier treat it versus something that is so multifactorial. So how many of you prescribe antidepressants? Okay, well, congratulations. You are some of the biggest prescribers in the country. And in fact, antidepressants are the most commonly prescribed medications in patients 20 to 59 years of age. So think about that for a moment. That is a big number of patients that are receiving medications for treatment-resistant depression, or other mood disorders, right? So antidepressants used to be, most of the antidepressants when I was training as a nurse back in the 80s were tricyclics and MAOs, right? Those are some of the old school ones. But then in the 80s, there was this major shift towards treating monoamine neurotransmitters. So the theory was that there is a reduction in serotonin, norepinephrine, and dopamine. And so big pharma started producing medications that addressed most of those. And so that's where in the 80s, there was generation of a lot of SSRIs, SNRIs, etc. All of those really trying to get an increase in some of these monoamine neurotransmitters. So interestingly enough, when I was training as a nurse, I hardly saw any patients on a lot of these medications. But then when I went back to graduate school, graduated, came back, and now I was providing anesthesia and asking people for their medications lists, all of a sudden now I was seeing lots of Prozac. And interestingly enough, in the late 90s, early 2000s, there were movies, right? Prozac Nation. Do you all remember that one? The young lady is totally dysfunctional, is ruining her life in college, wants to lose her virginity, does it, has major issues, starts drinking. Lo and behold, she gets Prozac and she's magically so much better. And then lots of books around some of that as well. So, gained a lot of popularity. But here's the interesting fact about some of these medications, is that despite thousands of studies that have shown efficacy or tried to show efficacy, it really is not still well established, okay? So there are some very high quality reviews, I would say as a researcher, with lots of great controlled studies that do show a significant improvement in depressed patients on these medications. But interestingly enough, there are just as many or a lot of studies that also show that these conditions being treated are not necessarily being treated that well, and it's not necessarily due to the medications. And so some of those studies are, again, pretty tight controlled studies that show minimal differences in symptoms between placebo and some of these antidepressants. And then some of the other factors are that there is a lot of publication bias towards effectiveness. And so that's why, even in our study, because I'm a clinician as well as a researcher, it was really interesting for me to think about my own self as a biased observer, right? And so that's why I'll explain a little bit more about the design here in a moment, but I blinded myself and all the providers to what the patient was getting. Yeah. Because I knew that ketamine worked. I'd seen it work. And in my brain, I also assumed that glutathione would work. So a little bit more about that as we talk about the methodology of this study. And then, unfortunately, pharmaceutical industry has a lot of sponsorship on a lot of these clinical trials as well. So just something to think about. And then really the other aspect of it is that about 30% of the patients, so those treatment-resistant patients, actually really don't respond to these medications. So then you start to wonder, well, is the monoamine dysregulation really the main cause? Could there be other causes of depression? And that's why in these certain individuals, and that's why in that population, we're not seeing great impact. So could we start to look at other biological processes that affect depression? What would that look like? What do some of those look like? Well, there's been a lot of research recently on the inflammatory processes in the body and kind of this imbalance of oxidative versus redox in the cell of patients who possibly have MDD and TRD. And so interestingly enough, pro-inflammatory cytokines and oxidative stress markers have been found in patients with major depressive disorder. And those, more interestingly enough, those with higher levels of oxidative stress markers actually tend to be the ones that are not responding to treatment. So that really then kind of makes it very interesting to start thinking about this model of depression, or at least a contributing factor to depression. So just kind of a review of reactive oxygen species, which actually tend to be byproducts of all of us metabolizing. All of your cells sitting here, you're metabolizing, your cells are working, and they are producing reactive oxygen species. But there's a very elegant system of balance that really maintains this what we call oxidative eustress, where there is kind of a balance of what's happening on the reactive oxygen species and then the molecules that can come along, pick them up, and process them. So generally speaking, we like to see hydrogen peroxide, which is one of the main byproducts, as being somewhere around 1 to 100 nanomolars in the cell. And so but when it is in the cell in those magnitudes, it actually serves a very useful mechanism for a lot of our processes, such as angiogenesis, wound healing, anti-inflammatory processes. So, it's not all bad. Reactive oxygen species are not all bad. They do provide some usefulness. But what happens is when there is a high level of hydrogen peroxide, for example, is one of these reactive oxygen species, is that it can actually cause non-specific, so meaning pretty wide damage to biological molecules. And those molecules include lipids, proteins, membranes, and nucleic acids. So pretty much everything that your cell needs to do its job. So it does really have, this effect in high levels. And that's what we call oxidative distress or oxidative stress. And so actually hydrogen peroxide at high levels can cause cell apoptosis and then at really high doses, necrosis. So that's all good and well in the cell, but what does that have to do with the brain? Well, the brain is extremely sensitive to reactive oxygen species. So in the brain, this system, this very elegant system, can't lose its elegance. It has to kind of maintain that balance between pro-inflammatory and anti-inflammatory cytokines. And so, what we found certainly in the brain is that in a lot of studies, actually, recently, we found that if you have a propensity of these reactive oxygen species that cause the release of cytokines, it can lead to disease, specifically mental health disease, such as depression. So, for example, research has shown that high circulating levels of cytokines like IL-6 are strongly associated with feelings of guilt and suicidal ideation. They've also done other studies that have shown high levels of cytokines in patients who are treatment resistant to some of the medications that we are prescribing. And so this very elegant balance between production of pro-inflammatory cytokines, which, by the way, you can't stop. That's basically how your cells function. They work, they produce reactive oxygen species. So that's on the one side. But hopefully on the other side, there is enough of production of anti-inflammatory molecules that can kind of maintain that balance. And one of the things that animals come in handy, animal studies come in handy, for example, is when we give animal models some of these pro-inflammatory molecules, then what we notice is that there is actually a neurosynapse degeneration, which leads to depression and depressive behavior, and kind of puts that animal at risk of then having kind of this propensity of reactive oxygen species with minimizing the good stuff, the anti-inflammatory. So lots of different studies. I have a reference list at the end of the PowerPoint. It's pretty extensive, so definitely you can go in and look at some of these studies. But just kind of as by way of summarizing, lots of studies that compared patients with matched controls, patients who have major depressive disorder with non-depressed controls, and then also matched controls of people who are treatment resistant versus non-treatment resistant. And really, one of the things that has been found is specifically that patients with these high pro-inflammatory markers tend to do poorly. They have much poorer outcomes and tend to be much more treatment resistant. And so some of the associated cytokines that we've observed in different studies that, again, I have the references for you in summarizing here, are, for example, elevations in interleukin 6 and 8, some C-reactive protein, and definitely TNF, tumor necrosis factor. And then on the other side, where we're kind of looking at, okay, what about the anti-inflammatory side of the house? What we're finding is a lot of research showing that T cells are lowered, and the cytokines associated with T cells are also decreased in this population. And then one of the interesting things is that some of these patients exhibit a decreased amount of glutathione in their circulation. So switching gears to glutathione, I'm sure most of you that provide glutathione already know this, but it is a tripeptide molecule made out of 3 peptides, cysteine, glycine, and glutamate. And it is our major intracellular antioxidant. And it really does a nice job of maintaining those redox reactions where it's kind of picking up the reactive oxygen species and helping us neutralize those. So in the brain, glutathione is actually the most abundant antioxidant. It has a very high affinity for glucose and oxygen. And I always used to teach the students that at the end of the day, the greediest organ for oxygen and glucose is the brain. It does compete with the heart for oxygen, certainly, but really the brain uses a lot of oxygen and a lot of glucose, and therefore produces a lot of reactive oxygen species, and so really needs, and it's very sensitive actually to having reactions to elevated reactive oxygen species. So it is a very important, glutathione is certainly extremely important in preserving the way the brain works, in maintaining synaptogenesis, making sure that the connections and the connectivity is working properly. And so it's an extremely important non-enzymatic, if you will, antioxidant. And studies have shown again that glutathione levels are lower in patients with MDD than in matched controls. And so what we started to think about was, let's go in the literature and see what people have done. Has anyone given patients glutathione to see, since there is lower, will it elevate the levels and will that have an effect on outcome? So let's bookmark that thought. And then I'm just going to give you a very quick review on ketamine and its actions. We kind of understand the whole model of how it works on depression, right? Or one of the biggest studies that demonstrate animal studies that demonstrated that, how we believe ketamine works is it blocks the NMDA. So there is a propensity of glutamate to be produced and to really be available now to interact with the AMPA receptor. So the way I used to teach it to the students was, imagine you're driving a car on two parallel streets. There's a car accident on one. Now the cars, instead of going down that road, have to go down another road, the parallel road. And so that's what ketamine does, is it blocks glutamate from interacting with its usual receptor, the NMDA, and sends glutamate to the AMPA receptor. And then the AMPA receptor, once it's activated by glutamate, then there is an opening of the voltage-gated calcium channels, and then that causes an influx of BDNF that leads to the cell's machinery kicking in via tyrosine kinase, mTOR, some of the kinases, and increasing protein replication and then synaptogenesis. So we understand that ketamine works that way, and we're all fairly happy about that one. But what about ketamine as an anti-inflammatory in itself? So how about if we start thinking about the fact that ketamine is not just an antidepressant or, causing this synaptogenesis happening, but what about its own anti-inflammatory effects? And so there have been a lot of research, actually, believe it or not, on ketamine and its effect as an anti-inflammatory. And a lot of models are from cell lines of animals, animal research. And then I really like this study that was just published in 2024. I do have the reference for you, where they exposed human cells to fetal cell line to kind of investigate, what does ketamine actually do in those cells. And what they found was that cells treated with interleukin 1 beta or IL-6 alone. So they did those cell lines alone, exposed to those cytokines. And then they also treated a batch to the R-enantiomer, or R-ketamine, and then another batch to S-ketamine. And as you recall, both IL-1 beta and IL-6 are pro-inflammatory. And what they found was that the cells that were exposed to both the R and S enantiomers actually had a reduction in neurogenesis and an increase in apoptosis. So they were able to show that even in the human cell lines, that there was some activity of ketamine with those inflammatory cytokines. So that's one study, but really what we think, and for those of us who've taught ketamine for decades, and we've looked at kind of the research that's come out, I think the more popular idea of how ketamine is an anti-inflammatory is really through the kynurenine pathway. So kynurenine, just to take you back to your biochemistry, is responsible for about 95% of total tryptophan catabolism. So that pathway is responsible then, and then just to take you back, tryptophan is a precursor for serotonin, melatonin, and some of the other molecules that have been implicated in depression. So we think that there is a dysregulation of HPA, which causes depression and causes some of the cellular activation of pro-inflammatory cytokines in the depressed patient. And so that was what the bulk of my research on animal models, where I exposed animals to chronic stress, and I observed that indeed they do become depressed, and there is some increased inflammatory biomarkers in the animals' circulating blood. But these are also some interesting studies in humans, and really thinking about the fact that ketamine works on that kynurenine pathway is really interesting. And this has been demonstrated in several studies over the last decade, where ketamine kind of pushes, instead of tryptophan being blocked from going from tryptophan to serotonin or melatonin, it actually causes a propensity towards that side of the reaction versus an increase in chironeurin itself. So that's kind of the general mechanism of action of ketamine as an anti-inflammatory, in my humble opinion. So that it's actually working on tryptophan and therefore helping to kind of level out serotonin and then melatonin as well. And then interestingly enough, there's been some research around, what are some of the biomarkers that people have found? And certainly there have been some studies that have found that, for example, that interleukin-6 has been a predictive biomarker for ketamine's antidepressant effects in some patients, especially with treatment-resistant depression. And again, I'll have all of the references for each slide, and those are at the end of the talk. Okay, so with all of that in mind, I'm sitting in my office one day and I'm thinking, okay, what do I want to do for my next research topic? And I have a group of students that I mentor every year, actually a couple of groups of doctoral students. And I thought, okay, I've seen and observed the way that ketamine works. And I've given ketamine patients, especially in our pain population, glutathione, and they've had really good results. So that's going to be my study. I'm going to look at glutathione as an adjunct to already giving people ketamine. So the overarching hypothesis was that probably individuals with major depressive disorder do have increased levels of reactive oxygen species. And so if I come along and give them an anti-inflammatory like glutathione, I'm going to do a really great job and save even more lives by combining the two. So the purpose was to see if adding it to our current standard protocol for our clinic would do the job. And so and then what we decided to do, what I thought we would do is, okay, with this group of students, we're just going to look at outcomes based on PHQ-9 and BDI-2. And then if we had good results, I was going to dovetail another study to this and look at circulating IL-6 and IL-1B with both treatment arms. So we designed a randomized controlled double-blind study. So we randomized the patients to group 1 or 2, either the control group or the experimental group. And everyone that was treating the patients with glutathione or saline were blinded, including myself. So everyone again, we were all blinded, and the patients were also blinded. They didn't know if after their ketamine infusion, they were receiving glutathione or if they were receiving normal saline. So, IRB. So we went after IRB at Georgetown, obviously, because these are Georgetown students. So had to get IRB from Georgetown. Georgetown said, yeah, sure. As long as it's de-identified data, the students can analyze it. You're good to go. So, but then they said, you're looking at glutathione and no one's going to really approve this unless you get an investigational new drug approval from the FDA. So, you know what? I'm glad you're laughing because you really do need a sense of humor to do research. Okay. So, yeah, sure enough, like a good citizen, I applied for an IND for glutathione, which, by the way, everyone from the reviewer to my own humble self has in every single cell. But okay, yes, let's apply for this investigational new drug. So I applied for the IND, and I'm just going to digress for a minute to tell you what a lovely experience. So yeah, I get a letter from the FDA. Yeah, so you got to do this, this, and this. Oh, and by the way, ketamine is extremely dangerous. So, okay, well, thanks for telling me something that I've been teaching for 25 years, but okay. So I explained a little bit about the glutathione and, the ketamine as being an FDA-approved drug. Your email is fda.org. Your organization is already FDA-approved the drug that I'm going to give, I'm not asking you for anything for ketamine. I'm asking you about glutathione. But oh no, 6 months later, back and forth on the glutathione being fine, but the ketamine being a major stickler in their minds. So they're writing me about something called Olsen bodies. How many of you have heard of Olsen bodies? Only bodies. Okay. How many of you have seen anything about only bodies since 1990, 2000s, 2010s, 2020s? Okay, what I want you to do tonight for homework, since I'm a professor, I'm going to give you homework, is to go to PubMed and put in exactly that, only bodies and ketamine. And what you will see is there are probably 15 studies that have anything to do peripherally with that, and maybe 2 studies peripherally with glutamate and ketamine. And what you'll notice is the author is only. Okay? Now, I've made some discoveries. You will not find a Ladan body anywhere in the research. Because anytime you do something and you put your own name on it and no one else can replicate it, that to me is a little bit of a red flag. So I scheduled a call with the young man. Well, I didn't know he was a young man. With the gentleman at the FDA. Get on the phone. He is literally sounds like my son's age, about 20. And I'm like, young man, I'm not sure what you're asking me for. The study, you're supposed to give me clearance for glutathione. And by the way, this only body business, I've been teaching ketamine for over 25 years. I've never had to teach it to medical students because it ain't a thing, at least not with ketamine. So the next day I got the approval. Yes, I used a very nice voice. And so we proceeded with the study once we got approval. And based on kind of our power analysis, we thought, okay, we'll get 18 total patients, do it as a pilot. But when we announced the study to our patients, we actually were able to recruit a lot more. So we were actually able to kind of hit an alpha of 0.05 to 95% confidence interval, and ended up with a final of 30 patients that we included in the studies. So all of them had to have a diagnosis of major depressive disorder by a psychiatrist. We also had 2 psychiatrists on the study. And we randomly assigned half to receive our standard ketamine and half to receive ketamine and then glutathione. Everyone received 6 treatments over 2 weeks. We wanted to kind of do the study quickly. Our usual protocol is twice a week for 3 weeks. But because it was, we didn't want to lose too many people, I always know that the shorter duration studies do better. So we did thrice a week for 2 weeks. And then the ketamine dosing, I kind of allowed for the provider and the patient. We always do this. We start with 0.5 milligram per kilo, and we do ramp up slowly at either 0.05 or 0.1 mg per kilo increments, depending on how the patient is doing, kind of conversing with them, how was your last treatment, et cetera, et cetera. So we did allow some flexibility, and we determined the dosing by patient response. And so we kind of did our standardized protocol. So then after the patients would come in, they would get their usual ketamine treatment with all the same monitoring, et cetera, et cetera. And then after infusion was done, we would either hang a bag of 50 cc's of normal saline or 50 cc's of glutathione that was mixed by someone trained to mix and was not participating in the study. So so none of the providers that were doing the treatments, nor myself, who was also one of the providers, knew what the patients were getting, and neither did the patients. And we did tell the patients that at the end of the study, we would unblind and let them know which arm they were in case they were interested. So our measuring tools were the PHQ-9 and BDI-2, and we did it at 3 time points. We collected data on day 0 before the patients came in for their infusions. On day 14, immediately after the protocol had ended for that specific patient, and then day 28 after the start of the protocols. We compiled the data, de-identified by a clinical staff, and then I collected that data, the de-identified data, and I sent it to my graduate students so that we could go ahead and shared it on our secure drive at Georgetown so we could analyze the data. So the demographics, age, gender, we looked at ketamine dosing, making sure that it wasn't, incongruent between the groups. And then depending on the treatment they received, ketamine versus, and saline versus ketamine and glutathione. And again, we collected the data. So the PHQ-9, you all probably know this better than I do, so I don't want to really belabor the point, other than we decided that a change of a score of 5 or greater reflected clinical improvement, and that was based on a lot of other people's research. And same thing with the BDI-2 that we used. And so the primary was PHQ-9, and then the secondary was BDI-2. And again, a change score of 5 or greater reflects clinical improvement. And then if there is a improvement of 10 to 19, that's really good improvement. And anything over 20 is a large improvement for the BDI-2. So we did some ANOVA statistics. And then if there were significant differences by group, then we did some independent t-tests with Bonferroni post-hoc analysis. So we simultaneously tested between control and experimental groups as well. So this is just kind of the demographic data. The gender was pretty well distributed between both groups. Really, there was no statistical significance at all between the age, the weight, how much ketamine they received, kind of mean total, and then the BDI pre and the PHQ pre between control and the glutathione group. And so what we found was that ketamine on its own and with glutathione had a huge impact on both the PHQ-9 and the BDI-2 from day 0 to 14. And what we found was that from day 0 to 28, BDI-2 wasn't as sensitive. So there was really not that big of a difference. But on the PHQ-9, there was a significant difference, continued to be a significant difference, even at day 28 in both groups. So this is just a graphical depiction of what I just said, that there was significant improvement in both groups on BDI-2 and PHQ-9. But when we looked at the interaction between group, we did not find any difference between those that received ketamine and normal saline and ketamine and glutathione. So there was no significant difference. They all improved. Every single patient improved, pretty much statistically significantly improved. We had really good outcomes, but really there was no difference in terms of between the two groups. And then again, like I said, on the PHQ-9, there was still significant improvement on day 28 for the patients. These are just some of the numbers that are in the paper. Again, I've referenced the paper, so don't want to necessarily belabor that. But what we concluded was that ketamine alone, so I talked to a lot of colleagues, a lot of researchers, and it was funny because their perspective was, look, if your control is too strong, you're not going to see a difference. So if ketamine is so effective on its own, adding something like glutathione may not give you that statistical significance unless you do a large study with a lot of people. Well, that's a cop-out for every research project, right? Hey, if I do 1,000 patients, I'm going to get significance. Well, yeah, of course you are, because now you're looking at a large data set, and anytime you increase N, you're going to increase the statistical chances that you're going to, get some significance. So that was one thought that we had. the whole notion of, okay, these effects lasting long, has anyone else demonstrated this? And we found some others had shown that ketamine's effects can last up to 20 days. So that was new to us, because the way we do our protocol is the patient does the induction phase, and then we taper the patients off slowly. So we have them skip a couple of weeks, a week or two, then come back for a booster, and then skip another 3 or 4 weeks, then come back for booster, and then continue kind of on a monthly 6-week regimen until. So when I did this study, I was like, wait, maybe they don't need to come back the next week, right? Like maybe we should wait 14 days before they even start to come back. And some people are, may not even need to come back in the first 2 to 3 weeks. So it was very interesting to kind of figure out even our own protocol, like, hey, what are we doing right? What are some of the things we could do differently? So like I said, maybe the ketamine alone was powerful enough. Maybe the glutathione is still providing some anti-inflammatory effect. So, the thinking is, okay, maybe we did have some anti-inflammation, but it wasn't enough of a change or a delta that it actually caused an effect, at least on our measuring tools. So it would have been interesting to, along with this, also do some blood work to see, where the levels of GSH, IL maybe 6 and ILB1, which ILB2, IL1, B2 was to kind of figure out, hey, does giving glutathione make an impact there? But quite honestly, the whole 8 months process of getting through IRB, I was like, oh my God, if we had added blood work to it, it would have heads would have exploded. So we just did with what we had, at least to begin with. And then the other thought was maybe because of its polar nature, right? Because it's reduced glutathione we're talking about. Maybe because of that, it's not able to cross the lipid membrane of the brain cells, of the blood-brain barrier. But before I designed this study, I did look at research that showed that there are some mechanisms that do exist in that bilayer for glutathione to cross the blood-brain barrier, but maybe that's endogenous and not if you're giving it exogenously like we are. And then there have been some in vitro studies that have demonstrated otherwise, but to me, in vitro studies, that's something happening in a glass jar, in a petri dish, in a lab. I don't know how much we can extrapolate from that. So it is possible that maybe there was a crossing the membrane issue, and so glutathione didn't have the impact we thought it might. So some future studies, I think it'd be really cool to maybe give patients the precursor to glutathione that is a little bit more readily available. And actually, there was a study published 2024, where they gave elderly patients aged 65 to 80 a dose of glycine and NAC, and they gave another group a placebo and kind of looked at their anti-aging effects. They looked at some biomarkers, etc. And they actually found the group that received an acetylcysteine had better outcomes via their measurements on some of this like anti-aging inflammatory markers. So, maybe giving patients, just an idea, we haven't done it, maybe we'll do it, but maybe giving people ketamine along with oral NAC and acetylcysteine is pretty well absorbed. Maybe doing it that way, or even IV and acetylcysteine afterwards, and kind of seeing if that does anything, or maybe even designing a research where instead of doing ketamine and glutathione, you're giving ketamine and NAC. So maybe that would be interesting. The other might be maybe giving patients some enzyme inducer that within the cell actually causes glutathione production. So maybe doing it that way might have given us a little bit better, more robust results. So some future thoughts for research, if any of you are interested in grappling with the FDA, please, move forward and be strong. I just do want to acknowledge the AANA Foundation, the American Association of Nurse Anesthesiology, who I received funding from for the research. And then my students that are now graduates and colleagues, the two physicians that I mentioned, the Avesta staff, Stephanie and Christina. Stephanie is here, and Christian. And most importantly, honestly, the Avesta patients that kind of went on this journey with us. It was really, really awesome. And then the rest of the slides are all the references, which is a lot. Great. Thank you. Any questions, comments? Yes.
Which I know this study was focused on flu, but will comorbidities taken into account, or would you study this for like ketamine with pain?
Yeah, I think so. We didn't have any comorbidities. And in fact, what we did was if patients had comorbidities, so if they had multiple diagnoses, that was an exclusion criteria. So this was very focused on MDD. I think it'd be really cool to do a pain study.
I wonder if we would have seen different results, at least in functionality, if that kind of stuff it was combined for
pain.
Yeah, I do a lot of ketamine. So
Oh, cool.
a lot these are probably this is that was the pain. So I include glutathione in there, kind of more from an anecdotal one, but it's standpoint research obviously, but instead making your body.
Oh, yes. Yes.
But yeah, I was curious if other symptoms were involved in your studies might have shown. Well, but we use 2 grams.
I use 2 grams. Yeah. Yeah. I always use 2 grams. Yeah. If I'm going to give glutathione, 2 grams is what I would give.
Okay.
Yeah. Because a lot of it does get excreted.
Yeah.
So I think, just understanding kind of its pharmacology, at least the one we give, exogenously, I give 2 grams. Otherwise, you're not in my opinion, you're not making any movement. Yeah. Yeah.
And then I know you used to wind it and get it afterwards, but you're going to do it, you don't put it into it with ketamine?
No, actually, because glutathione is such a good trash collector, I wouldn't mix it with anything because you're denaturing anything you put it in. So what we did was we did the ketamine first, we flushed the line with saline, and then we did the either saline or glutathione.
Thank you.
Yeah, of course. Of course. Yes, sir.
Did you get any information from the patients as to their subjective experience?
Yeah, so interesting you should say that because, I didn't design the study that way with some qualitative responses. But once we, quite a few patients asked, for unblinding, and they were like, well, I know. And I told them, hey, there was no difference. And a few patients were like, hey, I want to keep getting it because I feel really great after my depression's better, but I'm also able to exercise more. And, I feel more functional. So we had a few patients that when they came in for ketamine also wanted glutathione. So in the study, we provided the glutathione free of charge, obviously. But, we were like, okay, we charge for the glutathione. They were like, that's fine. Charge me because it's working for me. I love it. Keep giving it. So you bring up an excellent point in that it would have been very interesting to kind of gather information on that and what our colleague in the back raised that maybe for pain, even insomnia, understanding that ketamine actually pushes the renin pathway towards melatonin, people that were reporting better sleep. So really good point, sir.
What additional question? Is there any way to tell if the glutathione, feasible way to tell if the glutathione is actually getting studied?
Intracellular probably would have to be animal studies, right? Yeah. Which I've done a lot of, looking at rodent brains. That's really the best way to do anything where you want to look in the cell is animal studies. Unless you're doing it in vitro on, that's how I feel about that. And I feel bad being that way because I have so many colleagues in the pharmacology department or, they all do this cell lines. And I'm like, yeah, that's cool. But, what's that have to do with me? Whereas rats, we actually share about 99% of DNA with rats, which explains a lot. But any other question? Yes, sir.
So a related question, are there any tools you can say to see the intertime deficiency in brain areas? Perhaps like magnetic resonance spectroscopy at baseline and then post-treatment?
Yeah, that's a cool idea. Sure. Some of those, maybe even circulating, like we talked about some of the cytokines. But yeah, that's an interesting one. Yeah, why not? I think that's certainly an interesting idea. Yeah. It's very good. Yeah.
Did your client, you ever give glutathione at 9 a.m. or do you always, is it best to always be your blood IV or?
Always IV.
Okay.
Yeah, always IV if you're going to give it. And now, I mean, if you're in a clinic that doesn't do IV, maybe you could do oral NAC and see if you get some of that benefit. The study on the oral NAC, I think it's in the references. I'm almost 100% sure it's in the references. So you'll see.
OVE.
Yeah. Yeah.
You recommend it.
Okay.
Honestly.
Yeah. Very
well. Indeed, you guys do any IV and AMO remover?
No. No, that's another precursor. I just showed you that slide that, NAD does push that reaction towards glutathione. So yeah, that could be another one that would work. Yeah, those are all possibilities. And I'm glad that we got that, you all are also with me here thinking and like, hey, let's try some, because we're all in it together and we all want to see, the whole ketamine perpetuate itself, right? Like now I always tell the patients, you have these beautiful, very expensive new neurons, now let's keep it going. And so one of the things I explain is exercise. People are starting to give rapamycin, but, rapamycin getting into the brain is a whole thing as well. So instead of pushing the mTOR that way, why not tell patients to exercise? We know from exercise physiology that when you engage in rigorous exercise, you're causing release of mTOR, which guess what? Is how ketamine is working for neurogenesis. So we always tell patients, once you're more functional, we want you to start building a habit of daily movement. Start small, but we want to see you increase your heart rate, even if it's for 4 minutes, then 7 minutes, then 10 minutes, 15 minutes, and just get that mTOR going. So I explain all that to patients. We want to make sure that, so I think we're all in this together, that we're all thinking of what else can we do to keep it going so they don't have to keep coming back, perhaps, which some people don't. Some people do great and moveon.org, but other people, you're like, yeah.
Wipers. So you can get glutathione after each ketamine?
Yes. Yes. Every time, 2 grams every time. Or say you ran it for 15 minutes. Yeah.
Okay.
What dose would you use for the NAD plus? Oh, with that, I don't know. I don't give it, so I don't know. Yeah, you could probably find that in the literature, but I'm sure a lot of people do. Does anyone here give NAD that can answer that question? Yes, sir.
So I just get a question back, isn't that?
Oh, how much do you give? Is the question. What's the dose? Do you recall from your protocol? Okay, so maybe you can exchange info and thank you, sir. Yeah.
These are 50.
250?
About an hour and a half or so.
Okay.
Yeah, I have the stress and the blood going down there.
Okay.
And then I will take 500 or to get that 1,000.
Okay. And you're adding that as an additive to ketamine? Oh, just on its own. Okay, as an anti-aging type thing?
And if you add a little bit of caffeine into it, though, it helps to get through it.
See, so much awesome stuff happening out there. I can think of at least 6 research projects.
Did you see any adverse effects from giving it?
No, not in anyone. And, we give a lot of glutathione. Well, I shouldn't say a ton, but we do give glutathione fairly regularly. We have one patient that gets glutathione and ketamine. She loves it. That's what she gets. Never any issues. No, I think if you give it slow enough in the IV, over 15 minutes, I have never seen any issues. Have you seen any untoward effects from glutathione?
I never even.
Oh, you don't give it. Does anyone else give glutathione?
Here we do.
Have you seen any? Okay. How about you all? Yeah. Yeah, it's fairly benign, I think. Yeah. Yes.
I don't know if it was an aside, but were the patients, did they continue on their antidepressant meds?
Yes. We didn't change anything. We didn't want people, because we didn't want confounding factors. So everyone stayed on their regimen, whatever they were on. Yeah.
Yeah, true. Yeah. So something to add about any adverse mix of clinical promises. And you've had instances where patients get glutathione and their HSV would break out. And I think you mentioned it in your slides and called oxidative pollution.
Yes.
It can be too high,
It can.
too low.
Yes.
And that
It's very tight.
when one sick, it just has to be in the right range. So just getting the right baseline is
Would be great. Yeah. I agree. I think that would make it such a cleaner, such a cleaner model. Yeah, for sure. And yes.
Where do you purchase?
Where did we get the glutathione from? But I don't remember, but we had to have a special label that it was dangerous, that it was this. I had to take pictures of it. I don't remember. Maybe Olympia.
Probably.
Yeah, it was definitely one of those like FDA registered. That's the other thing. We had to show that we were getting it from an FDA registered.
I'm in California, so that's pretty. It's hard to find.
Yes.
Something.
Oh,
But I've had emails that haven't glutathione the people from Manpower that was shipped over.
yes.
And if you get some more Clark.
Yeah. And then the only other thing I'll mention about glutathione is you have to be careful because sometimes they put a preservative in it and people can have maybe an allergic reaction to the preservative, which I didn't know. I've never had any issues, but the FDA raised that with me. Like, hey, you got to get this special, glutathione. So we got it from the pharmacy. I don't remember. I'm sorry, I don't recall which, that had that version and they labeled, they gave us labels and we labeled it dangerous and
But there were preservatives in your glutathione.
no, the one we used was like one-time use, no preservative, etc. And so because I had the grant, I could get the, top shelf, top shelf, no preservative, blah, 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 to satisfy the FDA requirements. But honestly, when I give the glutathione now, I think I just give regular, whatever our curator purchase. What's that?
as long as it's California, we ship out IV,
Oh,
IN and subcutaneous.
as well. Yeah.
Yeah.
Which pharmacy?
Like farms.
Which one?
Strive.
Strive? Oh, we should get your information.
Absolutely.
Do you ship to the DC area?
Yes.
Okay.
All 50 states with the restriction law for California.
Okay.
Right.
And you're FDA registered? Perfect. All right. Any other questions? Thank you so much, everyone. Thank you.